Your blood tests came back normal. Your doctor reviewed the results, said everything looks fine, and sent you home reassured. Except that your body has been sending signals that something is changing. You are more tired than you used to be. You are carrying weight around your middle that will not shift despite eating carefully. You are experiencing brain fog that makes concentration harder than it was 5 years ago. And the blood tests that were supposed to detect problems early showed nothing abnormal at all. Normal blood tests are not a guarantee that disease processes are absent. They are a snapshot of specific markers at one moment in time, measured against reference ranges that are defined by statistical averages rather than optimal health, and interpreted through a lens that prioritizes diagnosing established disease rather than detecting dysfunction in its earliest stages. The standard metabolic panel that most people receive at annual health checks was designed in an era when medicine focused on identifying acute illness and advanced chronic disease. It does that job reasonably well. If you have severe kidney failure, your creatinine will be elevated. If you have uncontrolled diabetes, your glucose will be high. If your liver is actively failing, your enzyme levels will spike. But the vast majority of disease does not announce itself this way. Metabolic dysfunction, insulin resistance, chronic inflammation, hormonal imbalances, nutrient deficiencies, and early organ decline all begin with subtle changes that standard blood panels are not designed to detect, usually manifesting as vague symptoms like fatigue, weight gain, mood changes, or declining mental clarity that get dismissed as normal aging or stress. The problem is that by the time these early dysfunctions become severe enough to push blood markers outside the normal range, the underlying disease process has often been progressing for 10 to 20 years. And most people have been told repeatedly that their blood work looks fine while silent deterioration continues unchecked. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years in emergency departments, I have seen what happens when disease that could have been detected early is not identified until it becomes a medical crisis. And my goal now is to help people understand what standard blood tests actually measure, what they miss, and how to recognize when normal results are masking early dysfunction that needs attention. For the next several minutes, I want to walk you through exactly why normal reference ranges are not the same as optimal ranges, which critical markers are left out of standard panels, and what additional testing can reveal about your health before symptoms become severe enough to require emergency intervention. Okay, so if you are watching this video, you are probably concerned about your health despite being told your blood work is normal. And I just want to take a moment here to make you a promise. I promise to keep creating the most helpful, evidence-based videos I possibly can, grounded in clinical research and the latest medical science to help you live longer and prevent the diseases I see filling emergency departments every single day. And all I ask in return is that you give this fairly new channel a chance and hit the subscribe button. If you get to the end of this video and you did not think it was worth your time, or you have not learned something genuinely useful about interpreting your health markers, then feel free to unsubscribe, no hard feelings at all. But if you give me your time and attention, I will give you everything I have learned from over a decade in medicine and hundreds of hours reading diagnostic research. So please help me out, hit the subscribe button to help this channel reach more people like you, and let us continue with the video. How reference ranges are actually created. To understand why normal blood tests miss early disease, we first need to understand what normal actually means in laboratory medicine. When you receive blood test results, each marker has a reference range listed beside it. If your value falls within that range, it is marked as normal. If it falls outside the range, it is flagged as abnormal. This seems straightforward until you learn how those reference ranges are determined. They are not based on optimal health outcomes. They are not calibrated to detect the earliest stages of dysfunction. They are created by testing a large population of people, removing the outliers, and defining normal as the middle 95%. This means that if you tested 100 people from the general population, the reference range is simply where 95 of them fall. Here is the critical problem with this approach. The general population being tested is not healthy. It includes people with undiagnosed metabolic dysfunction, subclinical inflammation, early organ decline, and nutrient deficiencies that have not yet progressed to diagnosable disease. When you define normal as what 95% of the population has, you are including people in early-stage disease processes who have not been diagnosed yet. The result is reference ranges that are far wider than what represents actual optimal function. Research published in journals like Clinical Chemistry has documented that many standard reference ranges would need to be significantly tightened if the goal was to identify dysfunction early rather than simply flagging advanced disease. For example, the standard reference range for fasting glucose allows values up to 100 milligrams per deciliter to be considered normal. But longitudinal studies have shown that people with fasting glucose consistently above 90 milligrams per deciliter, still well within the normal range, have significantly higher rates of progression to diabetes and cardiovascular disease over the following decade compared to those with values below 85. The second fundamental problem is that reference ranges are population averages, not individual baselines. Your optimal value for a given marker might be quite different from the population average. If your thyroid-stimulating hormone has always run at 1.5 and it climbs to 3.8, that is more than a doubling of your personal baseline, even though both values fall comfortably within the normal range of 0.5 to 5.0. You will experience symptoms from that change: brain fog, weight gain, fatigue, cold intolerance, but your doctor will see a TSH of 3.8. Note that it is normal and tell you nothing is wrong. The test is normal by population standards, but for your individual physiology, it represents significant dysfunction. This pattern repeats across virtually every marker on a standard blood panel. Population-based normal does not equal individually optimal, and medicine has been slow to recognize this distinction. What standard panels actually measure? A typical comprehensive metabolic panel, the blood test most people receive annually, measures 14 markers. These include glucose, electrolytes like sodium and potassium, kidney function markers like creatinine and blood urea nitrogen, liver enzymes like ALT and AST, total protein, albumin, and calcium. A lipid panel adds total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. A complete blood count examines red blood cells, white blood cells, and platelets. Together, these tests provide useful information about severe kidney disease, liver failure, electrolyte imbalances, anemia, and grossly abnormal cholesterol. What they do not measure is equally important to understand. Standard panels do not measure insulin. This is perhaps the single biggest gap in routine screening. Insulin is the hormone that regulates blood sugar, and insulin resistance, where your cells stop responding properly to insulin, is the foundational defect underlying metabolic syndrome, type 2 diabetes, fatty liver disease, and much of cardiovascular disease. Insulin resistance begins developing 10 to 20 years before fasting glucose becomes abnormal. During this time, your pancreas compensates by producing more insulin to maintain normal blood sugar. Your glucose test looks perfect. Your hemoglobin A1C, if it is even checked, remains normal. But your insulin levels are climbing steadily, driving weight gain around the abdomen, increasing inflammation, raising blood pressure, and setting the stage for diabetes and heart disease. Research from the Diabetes Prevention Program, published in the New England Journal of Medicine, documented that people with elevated fasting insulin but normal glucose have dramatically higher rates of progression to diabetes. Yet fasting insulin is almost never measured in routine screening. Standard panels do not measure inflammatory markers. Chronic low-grade inflammation drives arterial disease, neurodegeneration, metabolic dysfunction, and accelerated aging. The most common marker, high-sensitivity C-reactive protein, can detect inflammation long before it causes diagnosable disease. Studies published in Circulation have shown that people with elevated hsCRP have double or triple the cardiovascular risk of those with low levels, independent of cholesterol or blood pressure. Yet hsCRP is not included in standard panels. Neither are interleukin-6, tumor necrosis factor alpha, or other inflammatory cytokines that predict disease progression. You can have silent systemic inflammation destroying your vascular health for decades, and your routine blood work will show nothing abnormal until the inflammation causes an actual event like a heart attack or stroke. Standard panels do not measure hormone balance beyond basic thyroid screening, and even thyroid testing is often incomplete. Most panels check only TSH, thyroid stimulating hormone, which is a pituitary hormone that regulates the thyroid gland. TSH can be normal even when free T3, the active thyroid hormone that actually drives metabolism, is low. Many people with symptoms of hypothyroidism, weight gain, fatigue, cold sensitivity, brain fog have normal TSH, but suboptimal free T3 that would only be detected with more comprehensive testing. Sex hormones like testosterone, estrogen, and progesterone are rarely checked unless specifically requested, despite their profound effects on energy, mood, cognitive function, muscle mass, and metabolic health. Cortisol, the stress hormone that when chronically elevated drives muscle breakdown, fat accumulation, immune suppression, and blood sugar dysregulation, is not part of routine screening. Standard panels do not measure nutrient status comprehensively. Vitamin D is sometimes checked, but deficiency is extremely common and associated with increased risk of cardiovascular disease, autoimmune conditions, depression, and infections. Vitamin B12 testing uses reference ranges so wide that people can have significant neurological symptoms from deficiency, while their B12 level is technically normal. Magnesium, which is involved in over 300 enzymatic reactions in the body and critical for blood pressure regulation, blood sugar control, and muscle function, is almost never measured. When it is measured, the standard serum magnesium test is nearly useless because it does not reflect intracellular magnesium status, and people can be severely deficient with normal serum levels. Iron studies are basic at best, often missing functional iron deficiency, where ferritin is low normal but not low enough to be flagged, causing fatigue and exercise intolerance that will not be attributed to iron unless more detailed testing is performed. The gap between normal and optimal. The fundamental mistake in how blood tests are used is treating normal as the goal rather than optimal. Normal means you are not sick enough yet to have crossed into the disease category. Optimal means your physiology is functioning at a level that supports longevity, energy, cognitive performance, and disease resistance. These are not the same thing. Let me give you concrete examples of how wide the gap can be. Fasting glucose has a normal range of 70 to 100 milligrams per deciliter in most labs. Research from longitudinal cohort studies has shown that people with fasting glucose consistently in the 80s have better long-term health outcomes than those in the 90s, even though both are normal. A fasting glucose of 98 is normal, but it is also pre-diabetic from a functional perspective, indicating that your body is struggling to regulate blood sugar effectively. If your glucose is consistently above 90, you have insulin resistance developing even if your doctor tells you everything is fine. The optimal range, based on outcomes data, is 75 to 85. Anything above that deserves investigation and intervention, not reassurance that you are normal. Hemoglobin A1C, which reflects average blood sugar over 3 months, has a normal range that extends up to 5.6%. Pre-diabetes is defined as 5.7 to 6.4%, but research published in Diabetes Care has documented that people with A1C values of 5.5 to 5.6, technically normal, have significantly higher rates of cardiovascular disease and mortality than those with A1C below 5.3. The optimal range appears to be 4.8 to 5.2%. If your A1C is 5.5, you are normal by lab standards, but you are at the upper edge of metabolic health and likely developing insulin resistance that will progress over time if not addressed. Thyroid stimulating hormone has an enormous reference range, often 0.5 to 5.0 milli international units per litre. Multiple studies have shown that optimal thyroid function for most people occurs when TSH is between 1.0 and 2.0. Values above 2.5, while completely normal by lab standards, are associated with increased risk of progression to clinical hypothyroidism, higher cholesterol levels, and more cardiovascular events. A TSH of 4.2 is normal, but for many people it represents subclinical hypothyroidism that is causing real symptoms and real metabolic dysfunction that will not be treated because the number is normal. Vitamin D deficiency is defined as levels below 20 nanograms per milliliter. Insufficiency is 20 to 30. Normal is anything above 30, but research from the Journal of Clinical Endocrinology and Metabolism and numerous other sources suggests that optimal vitamin D levels for immune function, bone health, mood regulation, and cardiovascular protection are 40 to 60 nanograms per milliliter. A level of 32 is normal, but it is far from optimal, and people with levels in the 30s have higher rates of respiratory infections, depression, and bone loss than those with levels in the 40s and 50s. Yet a doctor reviewing a vitamin D level of 32 will typically tell the patient it is normal and take no action. This pattern repeats across marker after marker. Ferritin, the iron storage protein, has a normal range that can extend from 15 to 300 nanograms per milliliter, depending on the lab. But functional iron deficiency, where ferritin is below 50, causes fatigue, exercise intolerance, hair loss, and restless legs, even though the value is normal. Optimal ferritin for most people appears to be 70 to 120. Triglycerides are considered normal up to 150 milligrams per deciliter, but research links values above 100 to increase cardiovascular risk. HDL cholesterol, the protective cholesterol, is considered normal as low as 40 for men and 50 for women, but optimal levels for cardiovascular protection are above 60. The normal ranges are not optimized for health. They are optimized for not missing advanced disease while minimizing the number of people flagged as abnormal. What gets missed in early disease? When disease processes begin, they do not start by pushing blood markers outside the normal range. They start by shifting markers within the normal range, or by affecting markers that are not routinely measured. This is how people can feel progressively worse, develop real symptoms, and still be told their blood work is fine. Let me walk you through how this happens in several common disease processes. Insulin resistance and metabolic syndrome begin with elevated fasting insulin and post-meal glucose spikes, while fasting glucose remains normal. Your pancreas is working overtime to produce enough insulin to keep blood sugar controlled. You gain weight around your abdomen. Your triglycerides start climbing within the normal range. Your HDL starts falling within the normal range. Your blood pressure creeps up from 120 over 80 to 130 over 85. Still considered normal or pre-hypertensive. Your inflammatory markers, if they were measured, would be elevated. But your standard metabolic panel shows fasting glucose of 94, total cholesterol of 195, and a doctor who says everything looks good. 10 years later, your fasting glucose is 112. You are diagnosed with diabetes, and you are told this came on suddenly. It did not come on suddenly. It was building for a decade while your normal blood tests provided false reassurance. Cardiovascular disease begins with endothelial dysfunction and arterial inflammation that elevate HSCRP, oxidized LDL, and lipoprotein A, while standard cholesterol panels look unremarkable. Your LDL is 130, which is normal, but if it were measured, your LDL particle number would be elevated, meaning you have more small dense LDL particles that are highly atherogenic. Your HSCRP would be 3.5, indicating significant inflammation. Your lipoprotein A would be high, a genetic marker of cardiovascular risk that is never checked in routine screening. You are developing atherosclerosis, but your lipid panel is normal, so no intervention is recommended. Years later, you have a heart attack, and everyone is surprised because your cholesterol was always fine. Thyroid dysfunction begins with subclinical hypothyroidism, where TSH is climbing within the normal range. Free T3 is falling within the normal range, and thyroid antibodies, if checked, would be elevated, indicating autoimmune thyroid disease. You experience fatigue, weight gain, cold sensitivity, brain fog, thinning hair, and constipation. Your TSH is 3.6, which is normal. Your doctor checks nothing else and tells you the symptoms are due to stress or aging. 5 years later, your TSH is 6.2, now officially hypothyroid, and you are started on thyroid medication. But the disease process was active and detectable years earlier. It was missed because normal TSH was interpreted as no thyroid problem rather than as insufficient information to rule out thyroid dysfunction. How to get better information from testing. Once you understand the limitations of standard blood testing, you can make more informed decisions about what to request and how to interpret results. The goal is not to become your own doctor or to demand unnecessary testing. The goal is to advocate for testing that actually detects dysfunction early when intervention is most effective, and to understand that normal ranges are starting points for investigation, not endpoints that rule out problems. Let me give you a practical framework for getting more useful information from blood work. The first step is requesting metabolic markers that standard panels omit. Fasting insulin should be measured alongside fasting glucose. If fasting insulin is above 10 micro-international units per milliliter, you have insulin resistance developing even if glucose is normal. Some practitioners use a calculation called HOMA-IR that combines fasting glucose and fasting insulin to estimate insulin resistance. A HOMA-IR above 2 indicates significant insulin resistance. Hemoglobin A1C should be checked to assess average blood sugar control over 3 months. An oral glucose tolerance test where glucose and ideally insulin are measured at baseline and then at intervals after consuming a glucose load can reveal post-meal glucose spikes and insulin dysregulation that fasting tests miss entirely. These tests are not exotic, they are widely available and relatively inexpensive. They are simply not part of standard screening protocols, so you need to request them specifically. The second step is requesting inflammatory markers that predict cardiovascular disease and overall health trajectory. High-sensitivity C-reactive protein is the most accessible and well-validated marker. A level below 1 mg per litre indicates low cardiovascular risk. 1 to 3 indicates moderate risk. Above 3 indicates high risk. This single test provides information about inflammation and cardiovascular risk that standard lipid panels completely miss. Some practitioners also measure fibrinogen, homocysteine, or lipoprotein-associated phospholipase A2, all of which provide additional information about inflammatory burden and cardiovascular risk beyond what total cholesterol or LDL can tell you. The third step is requesting comprehensive thyroid testing rather than accepting TSH alone as sufficient. A complete thyroid panel includes TSH, free T4, free T3, reverse T3, and thyroid antibodies, including thyroid peroxidase antibodies and thyroid globulin antibodies. This panel can detect subclinical hypothyroidism, T4 to T3 conversion problems, and autoimmune thyroid disease that TSH alone will miss. If you have symptoms of thyroid dysfunction, fatigue, weight changes, temperature sensitivity, hair loss, mood changes, and your doctor only checks TSH and says it is normal, you have not had adequate thyroid assessment. Request the full panel. If your doctor refuses, find a practitioner who understands that normal TSH does not rule out thyroid problems. The fourth step is assessing nutrient status more thoroughly than standard panels allow. Vitamin D should be measured and optimized to 40 to 60 nanograms per milliliter, not just kept above 30. Vitamin B12 should be above 400 picograms per milliliter, even though the normal range often extends down to 200. Methylmalonic acid and homocysteine can be checked to confirm functional B12 status when serum B12 is borderline. Magnesium is difficult to assess accurately with standard serum testing, but red blood cell magnesium provides better information about intracellular stores. Iron studies should include not just serum iron and hemoglobin, but also ferritin and transferrin saturation to detect functional iron deficiency. Ferritin should ideally be 70 to 120 rather than just above the lower limit of normal. The fifth step is interpreting results within optimal ranges rather than normal ranges. When you receive your results, do not just look at whether values are flagged as abnormal. Look at where they fall within the normal range. If your fasting glucose is 98, that is normal, but it is at the high end and indicates developing insulin resistance. If your TSH is 3.8, that is normal, but it is suboptimal and may be causing symptoms. If your vitamin D is 32, that is normal, but increasing it to 50 would likely improve immune function and energy. Use the optimal ranges I have described as targets rather than accepting any value within the normal range as fine. This shift in perspective from normal as the goal to optimal as the goal fundamentally changes how you interpret and act on blood test results. Now, I need to add an important medical caveat here. I am not suggesting that everyone needs to order extensive testing or that all abnormal results require immediate treatment. Some borderline values are benign, and some symptoms have causes other than blood marker abnormalities. What I am advocating for is appropriate testing when symptoms are present or when risk factors suggest early dysfunction might be developing, and for interpretation of results that considers optimal ranges and individual baselines rather than relying solely on population-based normal ranges. You should be working with a knowledgeable healthcare provider who can help you determine which tests are appropriate for your situation and how to interpret results in the context of your symptoms and health goals. Self-diagnosis and self-treatment based on online information is not a substitute for proper medical care. What I see in clinical practice, in emergency medicine, we see the endpoint of disease processes that were missed in their early stages. A patient presents with diabetic ketoacidosis, a life-threatening complication of uncontrolled diabetes, and when we review their medical records, we find that their fasting glucose had been creeping up within the normal range for years before anyone diagnosed diabetes. Someone comes in with a massive stroke and their records show they had borderline high blood pressure and borderline high cholesterol for a decade, both normal enough that no treatment was initiated until the cumulative damage resulted in a cerebrovascular event. A person arrives with heart failure, and when we look back, their symptoms of fatigue and shortness of breath were attributed to aging and deconditioning, while their underlying cardiac dysfunction progressed silently because their basic blood work and electrocardiogram were normal. What becomes painfully obvious when you work on the front line is that the normal blood tests and normal approach fails a significant percentage of patients. Not because the tests are measuring the wrong things, but because the reference ranges are too wide, the panels are too limited, and the interpretation focuses on ruling out advanced disease rather than detecting early dysfunction. The patient who advocates for more comprehensive testing, who understands the difference between normal and optimal, and who insists on investigating persistent symptoms even when initial blood work is reassuring, is the patient who catches problems early when they are still reversible. The patient who accepts that normal blood tests mean nothing is wrong is the patient who often ends up in the emergency department years later with preventable disease that has progressed to the point of crisis. The bigger picture here is that blood testing is a tool, and like any tool, its usefulness depends on how it is applied. Standard panels used with population-based reference ranges are adequate for detecting severe disease. They are inadequate for detecting the early metabolic, inflammatory, hormonal, and nutrient imbalances that drive most chronic disease development. If you want blood testing to actually help you maintain health rather than just confirming disease once it has developed, you need to understand what is being measured, what is not being measured, what is not being measured, how to interpret results relative to optimal ranges rather than just normal ranges, and when to request additional testing that goes beyond standard screening protocols. So here is what I want you to take away from this. Normal blood test results do not guarantee that disease processes are absent. They indicate that measured markers have not yet crossed thresholds that were designed to detect advanced dysfunction. Early disease, the stage where intervention is most effective and least invasive, is characterized by markers that are shifting within normal ranges or markers that are not part of routine testing. You have more control over early detection than you realize. It requires understanding the limitations of standard screening, advocating for appropriate additional testing when symptoms are present, and interpreting results with optimal ranges in mind, rather than accepting any value within the normal range as reassuring. This is not about becoming a hypochondriac who obsesses over every minor lab variation. This is about using available diagnostic tools intelligently to detect dysfunction early when it can still be reversed through lifestyle intervention rather than waiting until disease is advanced enough to require medication or emergency treatment. And finally, please subscribe to the channel if you found this video useful. It helps me reach more people who are trying to understand their health and get better information from medical testing. Thank you for watching.